Hi, everybody. This is Jeanne E. Poole. I am the editor-in-chief of the Heart Rhythm O2 Journal, and this is the October 2025 podcast. I'll be reading you the titles of the papers, who the first author is, and then either their key findings or the conclusion to the paper. We'll start off with a paper titled Pulsed Field Ablation versus Radiofrequency Ablation in Patients Undergoing Repeat Catheter Ablation for Atrial Fibrillation by Dr. Corinne Eisenegger and colleagues. The key findings of this paper are that first, arrhythmia-free survival was comparable between the pulsed field ablation and radiofrequency ablation groups undergoing repeat catheter ablation for atrial fibrillation. Second, the procedure time and left atrial dwell time were similar, but fluoroscopy time was longer in the PFA group. And third, the posterior wall isolation was performed in 4 of 5 patients in the PFA group compared with only 1 of 5 in the RFA group. The title of the next paper is The Impact of Sedation Strategy on Catheter Stability in Radiofrequency Ablation for Atrial Fibrillation by Dr. Luke Byrne and colleagues. The first key finding is that objective catheter stability can be measured using the standard deviation of XYZ coordinates obtained from the CartoVisitag module, with lower SD representing improved stability. Second, the use of general anesthesia resulted in a significant improvement in catheter stability over conscious sedation during radiofrequency ablation for atrial fibrillation. And finally, improved catheter stability was seen in the high-frequency jet ventilation group versus the conventional mechanical ventilation group during AFRFA. Up next is a paper titled Impact of Left Atrial Anatomy on Pulmonary Vein Isolation with Cryo-Balloon Ablation, Insights from the Randomized Controlled Compare Cryo Study by David Spreen and colleagues. The first key finding is that anatomical parameters can predict both acute and long-term pulmonary vein isolation success. Second, the absence of an orthogonal orientation of the left superior pulmonary vein and left inferior pulmonary vein was identified as a significant predictor of reduced first-pass PVI success. Third, the absence of an orthogonal orientation of the left superior pulmonary vein increases the risk of arrhythmia recurrence after 1 year. And finally, female sex was associated with lower first-pass isolation rates in the right superior pulmonary vein. The next paper is titled The Efficiency and Safety of Zero Exchange Workflows in Pulsed Field Ablation, Comprehensive Insights from the Disrupt AF Registry by Robert Eckhart and colleagues. The first key finding is, in clinical practice, zero-exchange pulsed field ablation workflows facilitated by Versa Cross Connect enable more efficient and predictable left atrial access than workflows involving exchanges. Second, zero-exchange workflows significantly reduce procedural times, largely owing to the streamlined workflow itself rather than the disease state. And finally, zero-exchange approach with Versa Cross Connect achieves left atrial access effectively, regardless of fluoroscopic guidance. The title of the next paper is Peri-Procedural Complications After Laser Balloon Ablation Procedures for Atrial Fibrillation, an analysis using the nationwide claims database by Ken Kawase and colleagues. The first key finding is that this study includes the largest cohort to date of patients undergoing atrial fibrillation ablation with a laser balloon. Second, the overall complication rate for laser balloon ablation was 3.2%, and there was no significant difference in the incidence of cardiac tamponade, emergency readmission, or in-hospital mortality compared with other ablation modalities. Third, laser balloon ablation was associated with a significantly higher incidence of perioperative stroke, 1.6%, compared with radiofrequency or cryoballoon ablation. And finally, stroke was the most common complication after laser balloon ablation. However, 86% of the affected patients were discharged home, suggesting that the events were generally mild. The next paper is titled De Novo Pulmonary Vein Isolation in Obese versus Non-Obese Patients Under Deep Sedation Does obesity increase procedure complexity? By Dr. Vera Maslova and colleagues. The first key finding is that obese patients tolerated deep sedation hemodynamically well with no significant differences in the number of hypotension episodes, mean arterial pressure levels, or degree of MAP reduction compared with non-obese patients. Second, although obese patients experienced more hypoxic episodes than non-obese patients, these were managed without complications. The median oxygen saturation level and first quartile remained above 90% throughout the entire procedure in both groups. Third, in multivariate analysis, obesity alone was neither a risk factor for hypoxia nor hypotension. Next, although the procedure duration and left atrial dwell times were longer in obese patients and they received a higher fluoroscopy dose, the safety profile remained comparable between the groups. And finally, recurrence-free survival did not differ between obese and non-obese patients. However, among patients with persistent atrial fibrillation, the recurrence rate was lower in the obese group. Next up is a paper titled High-Density Evaluation of the Arrhythmogenic Substrate in Persistent Atrial Fibrillation by Dr. Hasib Valley and colleagues. The first key finding is that left atrial low-voltage areas, considered to represent regions of arrhythmogenic fibrosis, increase the risk of atrial fibrillation recurrence after ablation. Second, adjunctive ablation targeting low-voltage areas is associated with improved freedom from AF. LA voltage and burden of LVAs are highly dependent on the atrial rhythm during mapping and the mapping approach used. Omnipolar technology yields higher voltages and in turn smaller LVAs than conventional bipolar voltage. However, there remains a significant difference between AF and regular rhythms. Finally, BIB thresholds 0.5 millivolts during coronary sinus pacing and 0.3 millivolts in AF correspond to a voltage of 0.84 millivolts and 0.40 millivolts respectively when 0T is used. The next paper's title is Comparison of Room Times Between Pulse Field Ablation and Very High Power Short Duration Ablation by Dr. Gabor Orban and colleagues. First key finding is that despite requiring deeper sedation, the author's study shows that pulse field ablation significantly reduces total room time, defined as the total time spent in the operating room by a patient, including anesthesia induction and emergence period, compared with the fastest radiofrequency technology, very high power, short duration. Second, PFA's total room time is 17 minutes shorter than the high power, short duration approach room time, without compromising 6-month recurrence rates. And finally, PFA is less operator dependent in total room time than high power short duration. Therefore, PFA minimizes variability linked to operator experience. The title of the next paper is Impact of a Care Process Model on Outcomes in Emergency Department Patients with Atrial Fibrillation by Dr. Rahul Ahuja and colleagues. The first key finding is that a well-designed care process model can meaningfully influence physician behavior in the emergency department, leading to more standardized care for patients with atrial fibrillation. Second, the care process model implementation was associated with a significant increase in oral anticoagulation prescribing rates, improving to 83% amongst eligible patients after excluding those with documented contraindications. Third, cardioversion rates modestly increased after implementation, reflecting improved physician confidence and access to structured follow-up care. Next, CHA2DS2-VASc score documentation improved significantly through the use of a best practice alert, enhancing risk stratification at the point of care. And finally, hospital admission rates for patients with AF decreased after the care process model, suggesting that improved frontline decision-making and reliable follow-up pathways can safely reduce inpatient utilization. The title of the next paper is Permanent Pacemaker Dependency After Transcatheter Aortic Valve Implantation, Prevalence, Patient's Characteristics, and Main Determinants by Dr. Enrico Ponti and colleagues. The first key finding is that permanent pacemaker implantation is still frequent after transcatheter aortic valve implantation, quoting an 18% frequency. Second, factors including pre-existing right bundle branch block, balloon predilation, male sex, and new onset left bundle branch block after the procedure are strong predictors of permanent pacemaker implantation. Third, approximately 36% of these patients remain pacemaker dependent at 12 months. And finally, baseline Q restoration and right bundle branch block and early new onset complete AV block 24 hours after TAVI are independent predictors of needing a pacemaker at 12 months. Next up is a paper titled Anatomical Considerations for the Non-Transvenous Implantable Cardioverter Defibrillator Implantation, a cadaver-based analysis by Dr. Peter Khalil and colleagues. The first key finding is that the intramuscular subcutaneous implantable cardiac defibrillator implantation technique offers improved outcomes compared with subcutaneous placement. Second, the cadaveric study provides crucial anatomical information not obtained through computed tomography scanning. Third, the anterior border of the latissimus dorsi muscle shows notable inter-individual variability but is consistently posterior to the mid-axillary line. Next, the long thoracic nerve lies close to the anterior border of the latissimus dorsi muscle, typically emerging near the fourth rib and entering the serratus anterior muscle at the fifth and sixth rib levels. Final, careful planning when applying the intramuscular technique is crucial for surgical safety and efficacy. The title of the next paper is Lack of Impact of Baseline QRS Morphology on the Right Heart during Long-Term Left Bundle Branch Pacing in Patients with Atrial Ventricular Block by Dr. Caitlin Pastrella and colleagues. First key finding is that the right ventricular activation time after left bundle branch pacing was similar in patients with atrial ventricular block, irrespective of the baseline QRS morphology. Second, left bundle branch pacing significantly improves left ventricular volumes and ejection fraction in patients with atrial ventricular block and baseline reduced values. Third, there were no significant changes in right heart echocardiographic parameters after long-term left bundle branch pacing in patients with atrial ventricular block, irrespective of the baseline QRS morphology. Finally, in patients with baseline bundle branch block, there was a slight increase in tricuspid regurgitation without reaching clinical significance. Next up is a paper titled Mapping the Future, Predictive Value of Commanded Electrogram Parameters for the Pacing Performance in Active Fixation Leadless Pacemakers by Dr. Takahiro Nomura. First key finding is that both the current of injury and the QRS amplitude derived from commanded electrograms were significantly correlated with the midterm pacing capture threshold after a VR leadless pacemaker implantation. Next, notably, these parameters were predictive even before fixation during the pre-mapping phase, highlighting their value in guiding fixation site selection. Third, cutoff values of greater than 2.0 millivolts for the current of injury and greater than 4.0 to 5.0 millivolts for the QRS amplitude may aid in optimizing fixation strategies and reducing the risk of elevated pacing thresholds within the first year. The title of the next paper is Transforming Electrophysiology Workflows with Natural Language Processing and Agnetic Artificial Intelligence by Dr. Akshar Patel and colleagues. The first key finding is that the authors applied named entity recognition, or NER, and text summarization techniques to contemporary electrophysiology research literature, successfully extracting key clinical terms such as medications, procedures, and outcomes. These methods generated concise summaries that highlight the feasibility of automated knowledge extraction from EP publications. Second, using a BioBERT-based NER model, the authors extracted relevant clinical entities, including propofol, QT, interval, and sevoflurane from a selected EP research article. Subsequent summarization revealed a clinically meaningful insight. Propofol mitigates corrected QT prolongation during sevoflurane induction, underscoring the potential of natural language processing NLP tools in surfacing actionable findings. 3. The authors developed a reproducible NLP pipeline leveraging Hugging Face transformers, BioBERT, and web scraping tools such as Beautiful Soup. The pipeline performed automated text extraction, entity recognition, and summarization with demonstrative outputs confirming its applicability to EP literature. Next, the authors introduced an agnetic artificial intelligence framework that distinguishes between basic task automation and agnetic behavior. Key features of this framework include autonomous decision-making, adaptive learning through feedback, coordination of complex subtasks, such as literature retrieval, entity extraction, and report generation, as well as the ability to handle exceptions in clinical content processing. Next, the authors proposed several use cases for agnetic AI in EP, including a literature agent that identifies, summarizes, and extracts key entities from new studies, a guideline agent that monitors and compares updates from professional societies such as the American College of Cardiology, American Heart Association, and European Society of Cardiology, and a reporting agent that produces structured evidence tables and summarizes tailored for clinical use. This study acknowledges several limitations, including the domain specificity of models, where general-purpose medical NLP systems may underperform on EP texts without fine-tuning, and the ambiguity of clinical notes due to abbreviations and jargon. Additional limitations include the scarcity of annotated EP datasets, the limited interpretability of deep learning models, and broader ethical and regulatory considerations involved in deploying such systems in clinical workflows. The title of the next paper is High-Density Atrial Mapping, P-Wave Analysis and Computational Simulations in Brugada Syndrome, Enhancing the Understanding of Atrial Fibrillation, by Dr. Beatrice Sanchi and colleagues. The first key finding is that patients with Brugada syndrome present marked P-wave parameter abnormalities, including prolonged P-wave duration. Second, P-wave parameters cannot identify patients with Brugada syndrome prone to atrial fibrillation. Third, total atrial activation time documented at high-density atrial mapping correlates positively with P-wave prolongation. However, the correlation is weak, possibly suggesting the presence of other factors contributing to prolonged P-wave duration. And finally, simulation studies showed that Brugada syndrome atrial models have a higher AF susceptibility and arrhythmia complexity, regardless of the presence and degree of atrial fibrosis. The next paper is titled Analysis of Application and Match Rates for Clinical Cardiac Electrophysiology Training in the United States by Dr. Jason Sylvester and colleagues. The first key finding is that growth in the annual number of applicants for electrophysiology training has exceeded the growth in the number of available training positions. Second, the number of unfilled training positions has decreased along with annual match rates. And finally, these trends are overall encouraging for the attractiveness of the specialty. However, future surveillance is warranted given projected shortages in the electrophysiologist workforce. The title of the next paper is Ventricular Dispersion and Repolarization in Marfan Syndrome, a Clinical Analysis by Dr. Raphael Spiegler and colleagues. The first key finding is that patients with Marfan syndrome are at high risk for ventricular arrhythmias and sudden cardiac death. Second, electrocardiographic parameters of repolarization and dispersion are altered in patients with Marfan syndrome, but their role in risk stratification may be limited. Third, patients with Marfan syndrome are at an increased risk of arrhythmogenic syncope, and those with Marfan syndrome and syncope are at an increased risk of sudden cardiac death. And fourthly, N-terminal pro-B-type brain natriuretic peptide levels were associated with a combined primary endpoint of ventricular arrhythmias or death in multivariable Cox regression analysis, whereas left atrial volume, male sex, history of atrial fibrillation, and normalized T-peak to T-end dispersion were associated only in univariable Cox regression analysis. The next paper is titled Increased Lipoprotein A Levels Independently Predict a Higher Incidence of Ventricular Arrhythmias, a Comprehensive Retrospective Cohort Study by Dr. Mariam Sani and colleagues. First key finding is that elevated lipoprotein levels greater than 75 nanomoles per liter are significantly associated with an increased risk of ventricular arrhythmias, including ventricular tachycardia, ventricular fibrillation, and sudden cardiac death. Second, after 1-to-1 propensity score matching to adjust for cardiovascular risk factors, patients with low LPA levels, equal to or less than 75 nanomoles per liter, had significantly better VA-free survival than those with higher LPA levels, with differences persisting over 20 years of follow-up. Third, Cox proportional hazards modeling in the unmatched cohort confirmed the association, showing a 14.5% reduced risk of ventricular arrhythmias in the low LPA group after adjusting for key confounders, hazard ratio of 0.55, p-value of 0.045. Next, the association between Lp(a) and VA seems independent of traditional atherosclerotic cardiovascular disease risk factors, suggesting additional pro-arrhythmic mechanisms beyond coronary artery disease. Finally, these findings support the potential utility of LPA as a biomarker for VA risk stratification and underscore the need for future studies evaluating LPA lowering therapies on arrhythmic outcomes. The next paper is titled Simplified Left Cardiac Sympathetic Denervation as an Acute Strategy for Recurrent Ventricular Tachycardia in Multimorbid Patients with Structural Heart Disease, a case series by Dr. Konstantin Krieger and colleagues. First key finding is stellate ganglion sparing left cardiac sympathetic denervation significantly reduced sustained ventricular arrhythmias in implantable cardioverter defibrillator shocks and multimorbid patients with structural heart disease. Second, the procedure was well tolerated with no major peri-procedural complications, thus supporting its use in high-risk patients who are not candidates for catheter ablation. And third, although left cardiac sympathetic denervation significantly reduced the arrhythmic burden, it did not eliminate recurrence in all patients, thus highlighting its role as part of a comprehensive multimodal treatment strategy. The title of the next paper is Leveraging Artificial Intelligence for Risk Stratification of Inherited Cardiomyopathies in Under-Resourced Settings by Dr. Salah Alawani and colleagues. The first key finding is that artificial intelligence enables scalable and cost-effective screening for cardiomyopathies in under-resourced settings by leveraging widely available tools like electrocardiograms, digital stethoscopes, and point-of-care ultrasound, reducing the reliance on advanced imaging and specialist interpretation. Second, AI-driven models can improve early detection and risk stratification of inherited cardiomyopathies by automating the analysis of clinical and physiological data and supporting diagnosis in primary care and community environments where access to traditional diagnostics is limited. And third, integrating AI into routine care helps overcome barriers to timely diagnosis, facilitates task shifting to non-specialist health workers, and supports broader access to life-saving interventions in low-resource environments. The next paper is a case report titled Biatrial Tachycardia in a Patient with Rheumatic Heart Disease, a case report by Dr. Tangshui Shen and colleagues. The key findings of what they learned were, number one, a diagnosis of biatrial tachycardia should be considered when most but not all of the cycle lengths recorded in only one atrial chamber. Second, typical anatomic isthmus line ablation can be a safe and effective choice for certain biatrial tachycardias, though more ablation lesions are needed. Avoid severe atrial conduction disturbance and atrial ventricular block. Finally, multiple anatomical isthmus ablation attempts often lead to left atrial appendage isolation. Therefore, left atrial appendage occlusion should be considered when slow blood flow is recorded in the left atrial appendage ostium. And of note, this was a Fellows case report for our Fellows section. The next paper is a research letter. The title is Extravascular Implantable Cardioverter Defibrillator Therapy in Patients with Genetic Heart Disease, an Early Single-Center Experience by Dr. Roxanne Codera and colleagues. The key findings include, number one, extravascular implantable cardioverter defibrillators seem to be a viable alternative to transvenous ICDs and subcutaneous ICD systems for younger patients with genetic heart disease, including athletes who do not require permanent pacing. Second, the EV-ICD shows similar safety and efficacy to those in the pivotal trials in younger patients. Third, 2 patients received appropriate life-saving shocks, and only 1 patient experienced inappropriate shocks owing to sinus tachycardia. And finally, most self-identified athletes who ultimately received an EV-ICD returned to their sport after EV-ICD implantation. The last paper in this issue is also a research letter, and the title is Improved Spatial Stability with a Flexible Tip Ablation Catheter in Atrial Fibrillation Ablation by Dr. Michael Hoffer-Halleck and colleagues. The first key finding is that a flexible tip ablation catheter, which is the FTAC, Tactiflex Abbott device, has been shown to have improved contact stability compared with a conventional tip ablation catheter, CTAC, Tacticath, also by Abbott, in preclinical studies. Second, catheter spatial stability and contact force parameters were more favorable with the FTAC compared to the CTAC during first-time radiofrequency ablation of paroxysmal atrial fibrillation. And finally, the improved contact parameters observed during RF ablation may apply to future use of the FTAC for pulsed field ablation. Well, that ends our October 2025 podcast. I hope you enjoyed hearing about this really amazing lineup of great papers, and I will talk to you next month in November.